So I'm going to thank you for the invite. It is always good to come and talk. But mine is that I thought I may end up in complications, but likely I did not. But let's show you the case. 76-year-old female sent by my partner for heart cath, and then chest pain, shortness of breath, large ischemia on the lateral wall by PET. Patient had a cabbage 2011, hypertension and CKD. And this is the angiogram. Let me because somebody recorded this with some sound. So what happened that in the diagnostic angiogram, we see that the left circumflex is dominant, and it has nasty long lesions in the mid and then in the proxima also. And then the LAD is occluded, but you can see that there is a competitive flow in the LAD. So on the right is small non-dominant, and then there is a graft, looks like going to the LAD, and there is a graft going to the diagonal, but the lima was actually atretic. And I thought this is atretic, but then once we got the op report, the lima had no flow during the surgery. The surgeon actually did the vein graft to the LAD, and then the lima was not basically used. So now with this, what we do? So should we? There is a large ischemia lateral wall. Patient has symptoms, and there is no graft to the left circumflex.
You have to go for it.
You have to go for LCX, sir.
So I tell you, my problem is that you can always say optimize medical therapy.
Yes.
But I have like 24 other partners. This partner, he gives me a lot of hard time. He doesn't believe in medical therapy, but that's besides the that's besides the point. But the patient does have symptoms, and the patient has CKD. So I did give him give her medical therapy, and because I did not want to do that on that day. Anyone who would be interested to do as ad hoc, go ahead and tell me what will be the plan. But I did bring her back.
What about her creatinine and creatinine clearance or EGFR?
CKD, ESRD. Yes, not good.
Also, I see that you are saying something.
So what about the creatinine level?
He is on ESRD.
So yes,
you need to unmute.
So I am
Hafiz bhai on ESRD.
Yes, ESRD.
Hafiz bhai, can you hear us?
No.
Hafiz bhai, can you hear us?
Hafiz bhai, mute.
Yes, there is some problem with.
It's not our. We are hearing ourselves, but I think he's not hearing us.
Yeah.
Okay. So yeah, it was my problem because I was not hearing
ESRD,
you.
on MHD or not?
No. Patient is CKD.
But you
stage
have written
3 or 4,
ESRD,
you know.
and stage renal disease.
No.
Not any stage. Yes.
You have
not in
written
this
there.
stage. Patient has creatinine like 2.6 or something.
Okay.
CKD.
Anyway.
Yeah, we'll have to ask Azam about stage 4 or stage 3.
What is EGFR?
Yeah, GFR is below 30. You know, good point. We calculate the GFR below 60, below 30, below 15. These are the numbers we remember.
So moderate CKD.
Yeah.
So
Hafiz bhai, I am the last person to do any intervention on this patient. I will keep the patient on to optimize medical management. Patient is anemic, patient is low, has low platelets count. So if I intervene, then I have to give dual antiplatelets for a long time. And patient has history of a stroke. So a lot of negative things are here. So I am the last person.
Did I miss
do
something? I did not.
intervention.
I did not say stroke, and the platelet was actually okay, but my threshold was
No, it is here.
no.
It is here, written here. A stroke.
No. Let me show you. So when
I
you
missed your point. I missed your point. But
so what I'm Mahbub, I'm just telling you in general.
এই যে এখানে দেখেন এই লেখা
No,
it
these
is
are
in
the
general.
general.
It is a general
I'm just
points.
giving you a general overview because yes, if my patient had platelets like 50, I would be reluctant. I'm saying when you deal with this situation, I usually remember 3 clear features: bad calcification, bad angulation, bad tortuosity. But our goal is to put the stent delivery, optimal stent expansion, and avoid complications. But you are right that this patient, anything we do may end up with the complication, nasty dissection, and this is repeat.
Sir, can we look at the angiogram once again before saying yes or no?
back. Yeah. This is nasty vessel, I think.
So,
But anyhow, the just at the junction of proximal and mid, just at the before the angulation, there is a tight lesion.
yeah.
You should prepare for either scoring balloon or maybe rotablation may be needed because post less dominant
So
LCA.
excellent, Ashok. You are just bringing up the thoughts. This is exactly what I was trying to say. That once we recognize this, we also recognize patient factor and the lesion factors. We all do that, and therefore, when we try to do not only the lesion preparation, we also make sure that the vessel is also somewhat prepared. And therefore, we need the guide support, the what wire, and are we prepared to deliver the stent? And we do this imaging business. That what is the main problem with the calcification? Is it superficial calcium, or is it deep calcium? Is it nodular calcium? And what is this? The thickness and the length, and then how many arcs involved? So with all that, then we prepare. What I'm trying to say that for preparing the lesion, we can use rotablator, we can use the orbital atherectomy, we can use laser, or now we have the lithotripsy. Whatever you use is not just one or the other. We can use in conjunction with that score balloon or cutting balloon, because we need to make sure that our toolbox is full. That's one thing. And then for the delivering the stent, you may still end up with the problem. And we have a plan A and we have a plan B, and then try to think about, what are the any other opinion. I have no ego to talk to my other buddies, hey, look at the film. So I was compelled to bring the patient back. So we had some plan, and I'll share with you. But preparing the calcium, in this case, I chose for rota, and we went with the bigger guide, a little, and then we took some pictures with the nitro, and then we went with the 1.5 bar. There is some technical issues that 1.5, but the lesion also distal. So to reach out, we had to advance the bar after barring the proximal, right? And then we give balloon.
Yes.
And then in the mid, see this balloon on the left? There is a little underinflated balloon. So what do we do now?
So distally, you have already inflated the balloon, yeah?
Yeah, but now mid, we have a problem. Because the balloon, look at the balloon.
So this is
the
not
balloon
inflated
is not fully inflated
at all.
Yeah,
so what we do now?
Yeah, you have what type of balloon you have used, Arif bhai? Yeah, Hafiz bhai?
What is that?
What type of balloon? Is a NC balloon or a scoring or a
It's a
cutting?
non-compliant balloon.
Yes, yes.
Is a
You
NC
can
balloon
use
have
a semi-compliant, but I tell you, you will be wasting your time
No,
to
why
use a.
why you are not using upfront the scoring or the cutting balloon there? Because now you're seeing that
Yeah,
that
very good
rota
thinking.
didn't help that much.
Saidur, very logical suggestion.
Because
Any
you
other
can't-
suggestion?
You can't go for a bigger rota bar here, because the rota bar also, what you have taken 1.5, it is 0.6 ratio already has been achieved here. So bigger bar, it will not be that much a good thing to think of.
I think
That's exactly the point. I
think
did go up with the step
Yeah.
bar.
Hafiz bhai,
I
putting
did go up with the 1.75.
You did
putting
go?
a body wire with this also, it may help some straightening of the vessel some
Okay.
extent.
Okay, Mahbub, hold your breath, because we did go up with the rota 1.75. Then we used, then still there was little underinflation. Then we used cutting balloon. And after the cutting balloon, it still was not going. What do you do now?
It's better to take the scoring balloon. Or
Okay, so
because if the-
scoring balloon, and then we got reasonable result, and then we took a long 30 balloon and inflated, and that was good. And now we want to go to the stent. The first stent went down, the second stent does not go.
the first one means distally
Yeah.
it has gone well, but the
Distal stent was
Somehow I got it, but the second stent did not go.
so the first time the LCX has permitted you, the second time it's not permitting it proximally. That's
Yeah.
that's really
no.
that's really
Sometimes it
nominal.
happens, Dr. Saidur. Sometimes it happens because
sometimes-
calcium.
Yeah,
Sometimes it
eccentric
happens
plaques
like
may
this.
crack. Yeah, may spicules may create some problem.
If
Exactly.
patient is not
Happen.
adequately
Yeah.
prepared,
What you do now?
You may dilate again with NC balloon.
Again, you'll have to go for the vessel preparation
So,
again and again.
Hafiz
You
bhai,
can take the Godzilla or some.
He has the Godzilla
Support-
there.
Yeah,
Oh,
He has the
exactly.
Godzilla.
No, I advanced the Godzilla more,
Godzilla
and
is
I
there.
had the luck. So you guys are giving me the right advice. So with the Godzilla, I got the stent down.
Mhm.
And then after that, once I got the stent, see this stent is little under, but we post dilated. And
I think the proximal lesion is uglier.
yeah, this is coming.
Another stent you are putting in.
Yeah. So
Covering the left
I'm
main
not worried
or-
about putting the stent into the little bit in the left main,
Yeah,
because
LAD
LAD is protected
It's a
anyway.
protected left main.
Yes, yes.
And then we got the final results.
So that is excellent.
So total
So,
three
you know,
stents.
we
Did you
do
do the-
procedures, but
Yes.
we are still frustrated. But if you look at the old trials, preparing the vessel, you know, modified balloon technique versus the lesion preparation, then you still see that they are competitive. And then in the TAVR era, we are now challenged that we do more complex cases, more and more. You know, we'll have to fix this, otherwise they cannot do TAVR. And therefore, I think we need to use everything that is in the toolbox. And it is not just one or the other. It is just use it, maybe in some cases altogether. And then whatever works. But in the prepare cal, even in current era, the recent trial, there was a significant crossover from the modified balloon technique, modified balloon meaning escalation of balloon and angioscore or cutting balloon, and not using the atherectomy device, then 16% versus 0% crossover. But overall, the late luminal loss,
That's why I wanted to ask you,
yeah,
because the Rotaxas also and the prepare calc both are
Very-
telling the late luminal
Yeah,
loss
Very
after 9 months is
interesting.
very
This is
bad.
very
and
interesting.
then even the clinical outcome was similar. But
Uh-huh.
remember, the issue is ultimately get the stent down, whatever way. My issue is that crossover significant from the balloon technique to this other. Sometimes we are not, we are not dealing with just individual patients. Individual lesions can be different, and preparation of the lesion is important and paramount. I have no problem to accept balloon, modified balloon and all that. Ultimately, if you can deliver the stent and expand the stent. That is the sort of message I get. In this trial, there was a significant crossover, and they did not do a routine imaging. So I don't know what would have been different, but they did actually show that the atherectomy devices, lesion preparation, you probably better off and not to worry about the crossover. One thing, the reason I showed this, if you don't assess the lesion very well and then go on high pressure balloon and without preparing the vessel, sometimes you can get nasty edge dissection, and then you cannot get there. Particularly, I was worried that if this is a dominant cert, if I end up in a nasty dissection distally, then I'm in a bad situation. So I protected the distal stent first, and then proximally march backward. And then once the stent is delivered, you can go high pressure and inflate this. Increasingly, we are dealing with these more complex cases. I think calcification, angulation, tortuosity, to me, it is like a mantra that if all three are there, then you know that this is going to happen. And therefore predict things and make sure that your toolbox is good. No shame in discussing and planning this with your colleague. And I like the colleague who criticizes most. I like the colleague who is more skeptical, because that colleague actually brings more things on the table. But underestimating is a problem. And I show you this, Dr. Paul Tierstein, he uses this often. Good judgment comes from experience, and experience, well, that comes from poor judgment. But if you share your experience, then good judgment will come and we'll avoid complications. Thank you.
Thank you very much.
Thank you, sir. So I have got one query regarding this this type of lesion.
Yeah.
Few months back, I just faced a similar situation, just like this, not dominant but codominant LCX, with 2O balloon that was well inflated. When I pushed 2.75 NC balloon, there was oozing. So that was not cracked. Even with 2830 ATM, that was not actually cracked. So lesion was as it was. There is no dissection, nothing else. Patient was symptomatic. So I kept the lesion like this because that was in our new cath lab on the other side in Darussalam. So all the advantage was not there. All the tools are not there. So patient till now is doing well. Previously he was effort angina. Now he is symptom free. So for last 3 months, I took her his telephone number. Initially, I called him sometimes, what happened, but he is doing well.
So what I can tell, Hafiz bhai, what I can tell here, I was talking with one of my colleagues here also, for this sort of calcium, especially the deep calciums. If you see
Yes.
the Renu Virmani's paper, that one has been, that deep calcium is actually as a cushion. It's an insulator. It's a stable. It's a stable thing. The nodules, the speckles, these are very creating thrombosis or other things, or abrupt closure of the vessel. So your deep calcifications has not been cracked by the balloon, rather a bit of superficial calcifications, but you have modified that one actually helped. The deeper one has been remained there, and that one is actually helping as a cushion. And these sort of patients actually, I think sometimes no data is available, but I think remains asymptomatic for a longer time. What Hafiz bhai says.
Well,
thank you
not
very much.
everybody
Thank you very
ends up in
much.
complication, but under expanded stent is a big
worse.
issue for stent thrombosis and also restenosis.
No, he didn't
So-
put a stand there. He didn't put a stand.
Ashok, you did not put a stent, right?
No,
No.
no, sir. I did
No.
not
Thank you very
put
much.
any
It is about
stent
fair
there because I have bad experience with the stent that
Now-
was underinflated and come back with restenosis.
Maske.